Thank you very much for the introduction, Adrian. It's an honor to be here and represent Canada in this session on the value of ECGs in the diagnosis and prognosis of channelopathies. I come to you as an ambassador from Canada. First of all, I've literally just completed my term as the president of the Canadian Cardiovascular Society and was previously the president of the Canadian Heart Rhythm Society. And I know how important it is to be able to hold these kinds of meetings and bring together the community to talk about those things that matter most to us in the area of heart rhythm management. I do have some minor conflicts of interest to declare, and these I do not think have any direct relevance at all to today's topic. So I just wanted to put that out there and say it's a pleasure to be here. As I was asked to give this talk and had a good exchange with Adrian, I was quite struck by how we continue to learn from the EKG, look back at something that's now 125 years old. And the beginnings of this is Willem Einthoven from the Netherlands talking about ECGs, the initial ECG, and ultimately winning a Nobel Prize about this. And amazingly, 125 years later, with not that much change in actually what's happened with acquisition of the 12-lead ECG, we continue to learn from it. So I wanted to start out by showing you this ECG and indicating context for it to illustrate several things. So the first is, this is a 45-year-old woman, and her sister had sudden death, and she then comes for assessment. She's otherwise well, has no meaningful health problems, and this is her resting ECG. And it's quite strikingly abnormal and raises the question about whether there's an underlying explanation, what the explanation is, how it relates to her own asymptomatic state as well as her family history. So, this is sinus rhythm. There's very low voltage. There's infralateral T-wave inversion, and this is quite strikingly abnormal. Professor Postema, who's speaking this morning, will talk to us a little bit about and is, I'm sure, struck by this ECG because this is the typical ECG of somebody who has phospholaminin cardiomyopathy. So this is a form of arrhythmogenic cardiomyopathy that leads to premature sudden death and can lead to cardiomyopathy as well. And the vast majority of cases are actually a founder mutation from the Netherlands, from the northeast part of the Netherlands predominantly. And so it would come as no surprise that this was a tall blonde woman who came in who had a Dutch heritage, who in fact carries the founder mutation and has asymptomatic phospholaminin cardiomyopathy. So again, the context combined with the ECG comes together to trigger an underlying diagnosis, and the ECG for people who work in this space and are familiar is quite diagnostic. Clearly, there's the need to complete the evaluation, including the details regarding her sister's death, the remainder of her cardiovascular investigations, and genetic inquiry. But nonetheless, the ECG in context is highly diagnostic in this situation. So that leads me to the question, how valuable is the ECG, or how do we use the ECG? So imagine in the heart rhythm space working without an ECG. It's inconceivable. When we look at inherited arrhythmia syndromes, 95% of them, if you like, have a characteristic ECG signature. So a good example that we'll hear about are things like Brugada or long QT. But the extent of the ECG changes are indicative both of the certainty of the diagnosis, but also the prognosis. And so a good example in Brugada is the type 2 versus type 1 pattern and the implications for that. We recently saw a paper looking at risk prediction in Brugada indicating that the spontaneous and persistent type 1 is a clear risk factor. This is not new, but it does support the idea that reviewing the complexion of ECGs is important. The second thing is that the severity of the changes needs to be combined with clinical presentation, because the ECG is a wonderful tool, but it is a contextual tool. And what I mean by that is that the combination of the ECG we saw in our previous case and the context of her sister's death led to arriving at a diagnosis. This ECG shows infralateral early repolarization, or inferior early repolarization is the portion I'm showing you. And this shows both ST elevation and notching, and can be a sign of health, if you like, in a young, athletic, typically male, enriched in people who are black. On the other hand, this finding that's amplified at the time of recurrent ventricular fibrillation typically at rest in an individual with otherwise no explanation for their cardiac arrest, could reflect early repolarization syndrome. So again, context is crucial for understanding the value of the ECG. But it also has its limitations. So things to consider as you understand this when we talk about the inherited arrhythmia syndromes. One is the variable penetrance and expressivity. So penetrance means that people carrying the same, for example, long QT variant may have varying degrees of QT prolongation and associated arrhythmias and symptoms. Expressivity means that the way in which a variant can lead to functional significance can vary within the same mutation or variant. So a good example is SEN5A can manifest as Brugada, as long QT, as conduction system disease, and rarely as cardiomyopathy. So a family can have a complexion of different clinical presentations, and that's variable expressivity. Professor Baranchuk is very interested in phenocopies and mimics, and so we see, for example, that with Brugada there are multiple things that can lead to mimics of Brugada, and even in an ECG like this, we may think this is early repolarization, but this patient could equally have pericarditis, even though the ECG is not typical for pericarditis. And so, again, because the ECG simply summarizes what's going on electrically in the heart from 12 different vectors, you have to think about the differential diagnosis in this situation. And the other thing is the ECG may be normal and provocation may be necessary to unmask the ECG findings that point to the inherited arrhythmia syndrome. And so a good example is sodium channel blocker for Brugada, or exercise or postural changes for long QT. The overlap with normal, like I showed you in this ECG with early repolarization, needs to be considered, and again, the clinical context is important. So here's an example of a young man. He was in his 30s and he had a previous unexplained cardiac arrest. And the ECG, of course, has its limitations, because if we look on the left here, these 12 leads, this is a very normal looking ECG, and he has previous cardiac arrest. And he came into the emergency room after having had an episode of syncope, and the emergency room called for us to interrogate his ICD. Shortly thereafter, he did this. And so now, all of a sudden, we've gone from a normal ECG to a clear diagnosis. So you might notice a very closely coupled ventricular ectopic initiating non-sustained polymorphic ventricular tachycardia. So this is short-coupled ventricular fibrillation, and this is a clear distinct syndrome, but the resting ECG is essentially unremarkable. There may be a little bit of overlap with things like short QT and early repolarization and Brugada, but the reality is this is a isoproterenol and quinidine sensitive arrhythmia that has a normal resting ECG, where you have to capture the rhythm strip to be able to detect and make the diagnosis. So I wanted to go down the path of covering something today that isn't in the other three lectures we're going to hear, and that's around this concept that illustrates the value of the ECG in the diagnosis of ARVC. And I wanted to quote Frank Marcus, who is the father of this whole realm, and indicate something that he said, that there is no gold standard for the diagnosis, and the diagnosis requires a combination of major and minor criteria encompassing structural, histologic, electrocardiographic, arrhythmogenic, and genetic factors. So with many of these conditions, there is a compilation of things which is often anchored in EKG changes to try to understand what the diagnosis is. And this is where the skill set of evaluating the EKG is so helpful. So a good example here with the task force criteria is we all know that the extent of T-wave inversion indicates the strength, if you like, of diagnosis, and typically the degree of to which the patient is affected. And that strength of diagnosis is also amplified if there's an epsilon wave. Epsilon waves are uncommon. They're not actually all that clearly defined, and they're typically a high-frequency deflection that occurs after the inflection point, after the QRS. And a putative epsilon wave is illustrated here by the arrow in the signal, and this is a major criteria. So again, we're using the ECG to compile and make the diagnosis. I'll remind you that last year we went through the process of changing some of the nomenclature in this area with labels and introducing the concept of arrhythmogenic cardiomyopathy. And arrhythmogenic cardiomyopathy includes ARVC, but also includes other presentations where an underlying condition presents predominantly with arrhythmia in the context of some form of cardiomyopathy. So not just desmosome-based ARVC, but some of these other conditions. And if you look at things like lamin AC or phospholamin, which we presented, or FLNC, for example, there are signature ECG changes. And I'll just take the example of lamin AC, where patients will have atrial arrhythmias, conduction system disease, and underlying cardiomyopathy, typically with a family history, and they may have extracardiac effects as well. So again, the ECG is placed in context and has a classic hallmark of findings, which includes the presence of atrial arrhythmias. So when things are tough, here's a little bit of advice about this, and that is, don't just look at the ECG in front of you, but obtain the old ECGs. The changes can be intermittent, and so a good example would be in Brugada or early repolarization. The findings can be intermittent. The other is look for rhythm strips that have been acquired through things like exercise tests, Holter monitors in emergency room acquisitions. As we always do in EP, look at where there are changes in rhythm, onsets, terminations, look at during acceleration and deceleration on exercise and Holter monitors, and then provoke those changes to try to unmask abnormalities. So this is just an illustration of a woman in her 60s who was actually being evaluated for atypical chest pain. And it turns out on family history that she had a daughter who died as a teenager. And the technologists were complaining that there was too much artifact on the ECG. And so the sharp eye will notice here that this ECG is not artifact. That's really something very compelling. So two things are going on here. So the first very striking thing is the degree of QT prolongation, but the other thing is the presence of T-wave alternates. And this is obviously highly significant because not only does it make a diagnosis of long QT, it also is uncommon but imparts risk associated with it, and also explains her daughter's death, and then provides an opportunity both to make a diagnosis in this woman and then screen, evaluate, and protect her family. So resources in this situation, one simple thing to do is just to call Adrian or email Adrian. He's enthusiastic about this, answers emails promptly, is very excited about anything where ECGs come up and questions surrounding that. There are 3 web-based resources that surround both the inherited arrhythmia syndromes and then have relevant materials. And because several of us were interested, Dr. Martin Green in Ottawa and I have had a long-standing friendship and interest in this, and one of our new consultants in the field, who was Dr. Green's fellow, and the 3 of us got together and compiled and put together a book on this topic. So if you are interested, this is a compilation, and each section is written by field leaders of ECGs with explanations that can be helpful if you're intrigued by this area. So I wanted to bring up one case that I think is an illustration, and that is we go back to the ECG that we started with in the young woman who presented with a family history of sudden death. But in a very similar kind of situation, we could see an obese diabetic who comes in with 3 hours of dyspepsia, and this kind of situation could lead to a diagnosis of an occluded dominant circumflex artery with an infralateral infarction. And the obesity explains the low voltage. And so again, a reminder that the ECG is a fantastic tool, but it is very contextual. So to conclude, the ECG anchors our approach to diagnosis. EPs have a special role in understanding and interpreting ECGs, and this continues to be the case in the cardiology and cardiovascular community. Make sure that you draw on all the materials available to you to use the ECG to the greatest benefit that you can. And remarkably, I think we're going to continue to learn more about ECGs over time, even though this is a time-honored tool. Thank you again for the opportunity to be here. I've provided my contact information, and I look forward to hearing the other lectures.